Hi there, my name is LaRocque. I'm currently enrolled in the anesthesia assistant program. Today we're going to be discussing how to set up an arterial line pressure transducer, as well as the reasons for doing so and the advantages and disadvantages of using this type of system. I've been using this current system that we have here for approximately 7 years. This is how long I've been in the operating room, so I am quite familiar with it. As you can see, I've already gathered up some of my supplies that I'm going to be needing, which includes a pressure bag that goes up to 300 millimeters of mercury, a clip for holding our arterial line, our pressure transducer line to connect to our screen, as well as we have here is a true wave arterial pressure monitoring kit that has everything included in it. So this would be considered our standard monitoring arterial line that we use. However, we do have the options of using an Acumen IQ sensor, as well as the FlowTrack sensor, which are both used with the hemisphere monitoring system that we also employ here at the St. John Regional tend to be more critically ill patients. Along with that, we also have a 500 cc bag of normal saline, which we will be using for the actual priming of the system. So as we are using that normal saline to be able to prime our system, it actually is a fluid fill monitoring system. And what that allows is when the catheter tip is placed into the artery, it then allows for that beat to be transmitted through that fluid filled system, which has a low compressibility, which allows that to be transmitted back. It's read through the transducer, interpreted into an electrical waveform, and then placed onto the machine so we can see how it's able to be there. This pressure system not only allows that, but also has the ability to be zeroed, so that we can zero it for where the patient currently is sitting on the level, and that allows that level to be moved up and down according to the bed height, or where the patient's at, or the size of the patient, or any number of things. Using this technology, you generally would like to use this in the operating room, the intensive care unit, the emergency department, anywhere that's really a critical care is a function, and that blood pressure monitoring needs a really tight monitoring, or they'd even be used for trending for really difficult patients that can either be hyper or hypotensive, or have a different variety of disease processes going on. So mainly critical care would be the big one. The advantages is, as I said, it provides a beat by beat reading of the blood pressure, systolic and diastolic, as well as a mean arterial pressure without having to figure anything out. So with reading that mean arterial pressure, you can find things like whether you're being perfused properly, and monitoring your systolic and diastolic pressure for hypertensive or hypotensive crises. And the best thing about it is that it allows for trending. So you can keep a tighter control of your blood pressure. It allows for you to titrate your medications better, so that you can have a nice, smoother transition in your blood pressures intraoperatively or during your care and critical care. So with that trending along, it also employs you to do quicker and better decision making, so that you'll be able to recognize a problem faster and be able to react to it quicker. The disadvantage of this system really is that it's more invasive, number one. So there's an increased risk of infection, there's an increased risk of bleeding, hematomas can develop and cause some compromise to the vasculature in that system. Those are all kind of patient related ones. Some other things that you need to consider too are is that it's a more technical skill. It requires more technical skill to put together, to be able to maneuver and manipulate, as well as some expertise and to decide what to do with those numbers once you actually are getting them all the time. Okay, so what we're going to go through now is the actual priming of the system, or how we prime them here at the St. John Regional. So the first thing I'm going to do is, as we're doing with anything, we should always clean our hands first. So cleaning our hands, first thing we want to do is Open our bag of normal saline, of course, as we always do, checking our expiration dates, and expires January 26th. So that is okay to use. So I set this onto the bed here. We open our True Wave, and again, checking our expiration dates, 2026, May 21st, so that's fine to use. We take and open our package. And first I withdraw the transducer. When I withdraw the transducer, what I generally do is I just remove the first outer laying of the wrapping. And then I have my system here. What I do then is I place it into the transducer so I'm having a spot to hold it. I take my bag and upside down, I remove the tab and remove the cap. I generally will pierce the bag and try to remove as much air as possible. As you can see, there's a little bit of leaking there. So I want to remove as much air as possible to try and remove any possibility of air being put into that system. So what I can do is take and just prime this drip chamber just slightly. I'm going to go ahead and hang it on to my pressure bag, and I'm going to close it, but I'm not going to pressurize it quite yet. I have found generally that it's better to be done under gravity. There's less chance for micro bubbles and that and the sort to develop through that, so I generally do that my ways. The next thing I want to do is make sure that my connections are all nice and tight. So double checking to make sure that those are all correct and in tight position. What I want to do is leave it off to the patient. I slightly open my free air cap, and what I'm going to do is pull on my drain, and then what I want to see is that fluid come and rise up. And I want to make sure that there's, what I'm doing while I'm doing that is checking for any signs of bubbles or anything in the system. And what I really want to monitor is that there's no pressure or there's no bubbles located on the top of that transducer, because that can dampen the waveform. What I'm going to do then is I'm just going to go ahead and open that back up. I'm going to come down to my next set of connections, retighten them, and do the same thing. I'm going to open that top and do another flush. And I'm going to try and flush that system all the way up. Again, trying to ensure that there is no air placed inside of it. I'm going to close that, and then I'm going to go ahead and finish flushing the system. Now that I've flushed the system, what I want to do is go ahead and double check to make sure that there are no air bubbles located within the system. So I'm going to place that there. And it is always policy in our hospital is that a dead ender is placed onto the distal end of the arterial line. This ensures that if this lock gets knocked back or anything like that, that the fluid or blood won't follow back up the system with the potential exsanguination or loss of blood of the patient. So we always want to make sure to double check that. The next thing I'm going to do is I'm going to go ahead and take my transducer from the monitoring system that we have here on our gas machine, and we're going to go ahead and connect this. And once I've connected that, I'm going to go ahead and prime this system to 300 millimeters of mercury. So as you can see here, it's marked right onto the side. We're going to go ahead and just go slightly past that 300. What I also like to do is once that's pressurized, I'm going to go ahead and give this system a really solid flush into a garbage can, and then making sure to go ahead and double check to make sure that there are no bubbles in that system. Now that we've gone ahead and primed that system and double checked to make sure that there are no bubbles, the other thing we want to do is to go ahead and zero that for the patient. So when we're zeroing that for the patient, the one thing that we are going to want to check is, as you can see my patient's located here, we want to make sure that the transducer is set at the proper level, which is known as the phlebostatic axis. The phlebostatic axis is found between the fourth intercostal space and about halfway through the anterior posterior of the chest, of the diameter of the chest. So want to make sure that that's zeroed, and then if it is to change, if the tables go up and down, is to go ahead and adjust that as needed. So if you look here, what I've gone and done is adjusted this to the phlebostatic axis of the patient. You can see that there, trying to fit it into the frame. So what I've done is I've gone ahead and done that. And then what I want to do is, now this transducer fortunately has an open air cap. So all we really need to do is go ahead and turn this off to the patient. I'm going to go ahead to our pressure line, our arterial pressure line here, and then I'm just going to go ahead and zero that. As you can see, it's coming up and it's zeroing. Now it is zeroed. I can now turn it off and go back to the patient so that it is ready to connect. I can also quarter turn it to make sure that it's not going to drip and leak out onto the floor, and I can go ahead and put that into standby. Now the system is ready to connect to the patient, and it should be ready to be able to be used. And once you're able to connect it, we can go ahead and open that back up to the patient, connect it, and you'll be able to get your arterial waveform. And that's everything I have. Thank you very much.